Hello, my name is Julie and I will be presenting the nursing management of the stroke patient. At the completion of this module, students will be able to discuss the incidence and risk factors for stroke, differentiate clinical manifestations and management of patients with transient ischemic attack and stroke, compare and contrast the etiology and pathophysiology of ischemic and hemorrhagic strokes, identify diagnostic studies performed for stroke patients, and describe the collaborative and nursing care measures for a stroke patient. Transient ischemic attack, or TIA, is a mini-stroke that occurs when a blood clot blocks an artery for a short time. The only difference between a stroke and a TIA is that with the TIA, the blockage is transient or temporary. TIA symptoms occur rapidly and are relative to the location and vessel affected. Unlike a stroke, when a TIA is over, there is no permanent injury to the brain. Symptoms last less than 24 hours, so patients often may ignore them. One-third of patients who have an untreated TIA will have a major stroke within a year. There's no way to tell if symptoms of a TIA will lead to a major stroke, and so this should be considered a warning. Like stroke, a TIA is an emergency. It is important to call 911. Medical management for transient ischemic attack includes modification of risk factors. Lifestyle changes such as smoking cessation, a healthy diet, and regular exercise should be encouraged. Medication therapy includes anticoagulants like Coumadin, Pradaxa, Xarelto, or Eliquis. Other medications intended to decrease platelet aggregation and prevent clot formation include aspirin, Plavix, Perzantine, or Agrinox, which is a combination of low-dose aspirin and Perzantine. Surgical interventions for TIA include a carotid endarterectomy, where the carotid artery is cut and the plaque is removed. The artery is then stitched up and normal blood flow is restored. Potential complications of this procedure include bleeding or bruising, nerve injury that may affect speech, tongue, or shoulder movement, blood vessel damage or blockage, and stroke. And transluminal angioplasty, also known as coronary artery stenting, entails similar risks of bleeding, bruising, but also allergic reaction or kidney injury, and stroke. In either surgical option, plaques can recur over time. Nursing interventions include observing the patient for post-op hypertension, assessing for cranial nerve damage, monitor for swelling or bleeding at the surgical site, and hyperperfusion syndrome. Stroke is caused by an interruption of perfusion to any part of the brain that results in the death of brain cells. Stroke is the fifth leading cause of death and the leading cause of disability. Stroke is considered a medical emergency and must be treated immediately to reduce permanent disability. 4 out of 5 families are affected by stroke in a lifetime. Stroke can occur at any age. 34% of strokes occur at less than 65 years of age and are a major factor in late life dementia. Stroke risk increases with age and women live longer than men. This is why 6 in 10 people who die from a stroke are women. The risk of having a first stroke is nearly twice as high for blacks as for whites, and blacks are more likely to die following a stroke than whites. Their mortality rate is nearly double. Hispanics' risk factor for stroke falls between that of whites and blacks. American Indians, Alaska Natives, and blacks are more likely to have a stroke than are other groups. A first-degree relative stroke risk increases with a strong family history of hypertension, atherosclerotic disease, and diagnosis of aneurysm. High blood pressure, high cholesterol, and smoking are leading causes of stroke. 2/3 of Americans have at least one of these conditions or habits. Lifestyle changes, as previously mentioned, should be encouraged, as well as light to moderate alcohol consumption. A higher rate of alcohol consumption increases the risk, and abstinence from certain drugs like cocaine or phenylpropanolamine are also recommended. Women who take low estrogen birth control pills may be twice as likely to have a stroke than those who don't, and the risk may increase if other risk factors are present. The circle of Willis is an arterial ring at the base of the brain and recognizes a compensatory system in the case of arterial occlusion. This circular structure of vessels supplies blood to the brain and surrounding structures. It consists of the anterior cerebral arteries, left and right, the anterior communicating artery, internal carotid arteries, left and right, posterior cerebral artery, left and right, and the posterior communicating arteries, left and right. The arrangement of the brain's arteries into the circle of Willis creates redundancy for collateral circulation in the cerebral circulation. If one part of the circle becomes blocked, narrowed, or stenosed, or one of the arteries supplying the circle is blocked or narrowed, blood flow from the other blood vessels can often preserve the cerebral perfusion well enough to avoid the symptoms of ischemia. If the blood supply to the brain is interrupted for more than a few minutes, cerebral tissue dies. The resultant disability depends on the location and amount of brain tissue affected. You can see here how the location of an infarct may impact a patient. The evidence of right side brain damage would include left side hemiplegia or neglect. The patient may deny problems, become impulsive, leading to safety issues, have poor judgment, or have perceptual or spatial defects. Left brain damage may be evidenced by right hemiplegia, impaired speech or language. Movements may be slow or cautious. The patient is aware of the deficits and may become anxious. They may also have impaired comprehension of language or math. An ischemic stroke occurs when a clot or mass clogs a blood vessel, cutting off the blood flow to brain cells. The underlying condition for this type of obstruction is atherosclerosis, the development of fatty deposits lining the vessel walls. Ischemic strokes account for 87% of strokes. In thrombotic strokes, the patient may wake with symptoms or is sedentary. There is usually no change in consciousness. Symptoms may have been preceded by a transient ischemic attack in the past and peak in severity within 72 hours. 2/3 of thrombotic strokes are associated with hypertension and diabetes, which accelerate atherosclerosis. In embolic strokes, there is an occlusion of the cerebral artery by an embolus from a distant source. This can occur with diagnoses of atrial fibrillation or emboli from a thrombus. The embolus lodges in an artery narrowing or bifurcation. Symptoms can be severe and may be temporary as the clot breaks up. Hemorrhagic strokes result from a weakened vessel that ruptures and bleeds into the surrounding brain. The blood accumulates and compresses the surrounding brain tissue. The two types of hemorrhagic strokes are intracerebral and subarachnoid hemorrhage. Intracerebral hemorrhage, or ICH, occurs when a blood vessel bleeds into the tissue deep within the brain. Subarachnoid hemorrhage occurs when a blood vessel on the surface of the brain ruptures and bleeds into the space between the brain and the skull. This can be seen with aneurysms or arteriovenous malformations. Hemorrhagic strokes account for the remaining 13% of strokes. Intracerebral hemorrhages are related to hypertension. There is a rupture of the vessel without warning, and the vessel bleeds into the brain tissue. This may occur during periods of activity with rapid severe symptoms like headache, nausea, vomiting, and decreased level of consciousness. The patient may have an increased intracranial pressure and cerebral edema, both of which must be treated. The prognosis is poor in intracerebral hemorrhages. Subarachnoid hemorrhage can be seen in aneurysms, a balloon-like bulge in an arterial wall. As the aneurysm grows, it can become so thin that it leaks or ruptures, releasing blood into the spaces around the brain. The patient may experience violent or thunderclap-like headaches, changes in level of consciousness, vomiting, stroke-like symptoms, and increased intracranial pressure. Headache symptoms may be due to the bulging of the aneurysm or bleeding. A rebleed in 24 hours to 14 days is common if the aneurysm is left untreated. The treatment for subarachnoid hemorrhage is surgery, most commonly clips or coiling. Patients are placed on complete bed rest with the head of the bed at 30 degrees, TED stockings on, and fluids being maintained. Complications from aneurysm include rebleeding or vasospasm. The warning signs of a stroke or brain attack include sudden weakness, paralysis, or numbness of the face, arms, legs, especially on one side of the body, sudden dimness or loss of vision in one or both eyes, sudden loss of speech, difficulty speaking or understanding speech, unexplained sudden dizziness, unsteadiness, and loss of coordination, and the sudden severe headache often described as a thunderclap. It is time to call 911. Diagnostic studies include a CT scan which differentiates between a bleed or ischemia. The first CT is completed upon arrival to the ED and then again 6 hours later to review the evolution of the stroke. The MRI looks at the extent of soft tissue injury or brain injury. The MRA looks at cerebral circulation for occlusion. The lumbar puncture assists with a subarachnoid hemorrhage diagnosis. There may be Doppler studies, an EKG, or a transesophageal echocardiogram. The transesophageal echocardiogram, or TEE, is a test that produces pictures of the heart and the arteries that lead to or from it. The TEE uses high-frequency sound waves or ultrasound to take detailed pictures. It is used to find problems in the structure and function of the heart. The TEE can give clearer pictures of the upper chambers of the heart and the valves between the upper and lower chambers of the heart than standard echocardiograms. The CT image on the left shows a slice of the brain with a right hemispheric ischemic stroke. The CT image on the right shows a right hemorrhagic stroke. The brain, like real estate, is all about location. The location damaged by the loss of blood flow determines the patient's deficits. This picture depicts what an evolving stroke might look like. The structural lesion is the ischemic core. It uses the existing oxygen and glucose to remain viable. This can only last for minutes because there is no more glucose or oxygen being delivered. The penumbra is an area where the circulation is compromised and blood flow is reduced. However, collateral vessels keep it viable, and this can last for a few hours. Early identification and treatment of stroke is critical to limit its damage. Medication therapy to treat stroke includes nimodipine, a calcium channel blocker that decreases the effects of vasospasm. Vasospasm decreases cerebral blood flow due to blood degradation typically occurring 3 to 10 days after subarachnoid hemorrhage. Another medication is the administration of recombinant tissue plasminogen activator, or TPA. This can only be given within 3 to 4.5 hours at the onset of symptoms. A stroke code or stroke alert is called. The physician must differentiate if the stroke is an ischemic or hemorrhagic event. Strict criteria for patient selection and administration of TPA can be viewed at the American Heart Association's Get With The Guidelines. The risk of intracerebral hemorrhage is acceptable given the clear benefit of treatment without increased mortality. Subsequent clinical practice data shows the use of outside clinical trial settings maintaining similar risk-benefit profiles using TPA. In an ischemic stroke, there is an obstruction within the blood vessels that supply blood to the brain. The goal in treatment of such a stroke is to restore blood flow through these blood vessels. The Mercy Retriever does so by allowing the removal of blood clots causing the obstruction. The retriever consists of a long thin wire with a helical coil formed at the distal end. The balloon catheter is snaked into the affected vessel from the femoral artery, and the balloon is inflated to prevent blood flow that could hinder the retrieval process. The retriever is then fed through the catheter, during which the distal coil is straightened to fit through the catheter tube. When the retriever emerges at the clot site, the coil reforms, wrapping around the clot and allowing the clot to be moved with the catheter. Aneurysm clipping is a surgery performed by craniotomy. A tiny clip is placed across the neck of the aneurysm to stop or prevent aneurysms from bleeding. The small clip is placed across the base or neck of the aneurysm to block the normal blood flow from entering. This clip works like a tiny coil spring clothespin in which the blades of the clip remain tightly closed until pressure is applied to open the blades. Clips are made of titanium and remain on the artery permanently. On the right is a coiling. A microcatheter is inserted into the femoral artery and navigated to the targeted cerebral artery. Upon reaching the aneurysm, the coil is released from the microcatheter into the aneurysm sac. Coils are inserted until the aneurysm is densely packed. Detachment is triggered by a small, direct electric current. The coils provide a framework which promotes thrombus formation, limiting blood flow into the aneurysm. If endothelial cells successfully grow across the aneurysm neck, blood flow will no longer enter the aneurysm, preventing rupture or recurrence. Here you see an anterior communicating artery aneurysm before and after coil embolization. This procedure is performed in interventional radiology and is less invasive than an open craniotomy. The treatment goals of acute stroke are to preserve life, prevent further brain damage, and reduce disability. Maintain your patient's airway and oxygenation. Check for a gag reflex and swallowing. Pulmonary toilet if and when appropriate. An elevated blood pressure within parameters is okay and needed to maintain cerebral perfusion, preventing vasospasm. Vasospasm is an arterial spasm that leads to vasoconstriction. This can lead to tissue ischemia and tissue death or necrosis. In subarachnoid hemorrhage, Triple H therapy, or hypertension, hemodilution, and hypervolemia, continues to be the gold standard of care. Treat a MAP over 130. The normal is 80, but with higher pressures, the MAP may ride higher as well. Glucose must remain below 150. Keep your patient hydrated with normal saline, and the head of the bed at 30 degrees. Monitor for increased intracranial pressure. For subarachnoid precautions, decrease the stimuli, maintain the head and neck in alignment, avoiding hip flexion, and do not administer enemas. The NIH stroke scale assesses stroke severity. Be aware of the patient's level of functioning prior to the stroke. Common deficits seen in stroke include impaired urinary elimination. The patient may have partial sensation and control of their bladder. They may have cognitive deficits that impair their elimination. A toileting schedule may need to be initiated. The patient may also have impaired bowel elimination. This can be affected by changes in level of consciousness, immobility, and dehydration, which contributes to constipation. Treat your patient with stool softeners. Allow the use of a commode and assist with standing. Impaired physical mobility may also be a problem. Assist your patient with proper positioning and transfers. Ask for a physical therapy and occupational therapy consult if they are not already ordered. For impaired swallowing, the first evaluation of swallowing may be performed by the bedside nurse. Following that, speech therapy would be consulted for an assessment of speech, swallowing, and recommended consistency of food and fluids. To maintain the respiratory status of your patient, pulmonary toilet them except with bleeds or aneurysms. The National Institute of Health Stroke Scale is a systematic tool designed to measure neurodeficits most often seen with strokes. It is also used to standardize and document a reliable and valid neurological exam, and helps determine the level of stroke severity. Patients are given points for deficits. Nurses need to be trained and certified to perform the NIH stroke scale. There are 11 items included: level of consciousness questions, level of consciousness commands, the patient's best gaze, visual field exams, facial palsy exam, motor arm and motor leg exams, limitaxia, sensory exams, the best language response, dysarthria, extinction, and inattention. The NIH stroke scale takes less than 10 minutes to perform. There is a range of scores from 0 to 42. The lower the score, the less the impairment. Cardiovascularly, patients would be monitored on telemetry and DVT prophylaxis initiated. Patients may have impaired verbal communication. The speech area is located in the left hemisphere for 95% of people. In Broca's, or expressive aphasia, the patient is unable to convert thoughts to meaningful language. There may be outbursts of profanity. The patient is aware of this deficit. In Wernicke's, or receptive aphasia, the patient can hear, but there may be impaired comprehension of verbal and written language. They may have fluent, unintelligible speech. Or dysarthria, which is impairment of the muscles that control speech. Communication techniques may include picture or letter boards, and again, speech and language therapy. The patient may have disturbed sensory perception. They may have heminominous hemianopsia and diplopia, decreased sensation, or neglect. The patient may experience labile emotions, loss of social inhibitions, and decrease tolerance to stress and depression. Provide emotional support to the patient and the family. Break down difficult tasks into small steps. Distract unacceptable behavior to a productive task, and monitor for depression and treat appropriately. Thank you for taking the time to listen. Please don't hesitate to contact your instructors or myself with questions.